also my sister Mariam Natsakarian, who also contributed to data collection. Doctors Azatuhi Ashodjan and Temine Galichan for helping with the medical records. And all of my friends for supporting me. Also, I would like to say thank you, Fahe, for supporting me and being next to me. Thanks.
Okay, great. Now we proceed to the second presentation by Vartuhi Hayrumyan.
Hello, dear colleagues. My topic is about smoking cessation after acute myocardial infarction among patients of Nokmarsh Medical Center in Armenia. This is a cross-sectional survey. So I will present the background, aim and research questions, methods, result, discussion, conclusion, and make some recommendations. So we start with the definition of myocardial infarction. It is myocardial cell necrosis caused by significant and sustained ischemia. It is mainly an acute manifestation of atherosclerosis-related heart disease. So cardiovascular diseases are #1 cause of death and disability worldwide. It accounts for 30% of all deaths in the world, and over 75% of all CVD deaths occur in low-income and middle-income countries. Coronary artery disease is the most common cause of CVD deaths, and it accounts for 7 million deaths each year worldwide. In Europe, coronary artery disease accounts for an estimated about 2 million deaths each year. And myocardial infarction is one of the most major clinical manifestations of coronary artery disease. So there are modifiable and non-modifiable risk factors for developing coronary artery disease. Main modifiable risk factors are high blood pressure, tobacco use, high glucose level, physical inactivity, overweight and obesity. And the main non-modifiable risk factors are age, gender, family history of having coronary artery disease. So literature suggests that prevention programs improve survival for all types of coronary artery disease. And major modifiable risk factors for recurrent of coronary artery disease are the same as the risk factors for its development. And the main preventive lifestyle recommendations according to guidelines are smoking cessation, healthy diet, limited alcohol consumption, physical activity, weight management, blood pressure maintenance within goal levels. So literature suggests that smoking cessation after myocardial infarction reduces all-cause mortality and over 45% mortality of coronary artery disease. And there are many factors associated with the smoking cessation after myocardial infarction. And some of them have strong evidence in the literature. Those are level of nicotine dependence, length of hospital stay, prior attempts of quitting smoking, self-efficacy in depression, and some of them have contradictory findings in the literature. Those are presence of comorbidities, presence of other risk factors of coronary artery disease, severity of coronary artery disease, no smoking advice received by the physician, social support, and social demographic characteristics. So situation in Armenia regarding coronary artery disease epidemiology. It is #1 cause of death in Armenia as well. It accounts for 38% of total deaths, and age-adjusted death rate 323 per 100,000 of population. And smoking prevalence according to the AGS Armenia 2010 among men is 63%, which is the highest in European region. But for women, findings are contradictory. And according to same DHS data, it is only 2%, but according to some other sources, it reaches 14-15%. And no research was conducted in Armenia to explore smoking cessation practices and factors associated with smoking cessation after myocardial infarction. That's why we chose the topic, and we decided to investigate the smoking cessation practices and the factors associated with smoking cessation at 6 to 12 months after hospitalization among patients who were hospitalized at North Marsh Medical Center with AMI and who were smokers at the time of acute myocardial infarction. So research questions are: what is the prevalence of smoking cessation at 6 to 12 months after experiencing myocardial infarction? What are the factors associated with quitting smoking after AMI? And what are the methods, reasons, and main barriers for smoking cessation among post-AMI patients? The study was a cross-sectional survey. Study population includes patients who experienced AMI and were hospitalized at North Marsh Medical Center from March 2015 to August 2015. Inclusion criteria were being a smoker at the time of AMI, which was checked by from medical records and through screening questions before the interviews, being above 18 years old and having contact numbers in medical records. All eligible patients from March to August were included in the study, and data collection was done through medical record review and interview administered telephone survey. So dependent variable is smoking cessation at 6 to 12 months. Independent variables include socio-demographic characteristics, smoking behavior, level of nicotine dependence, severity of AMI, presence of comorbidities, presence of other coronary artery disease factors, and self-efficacy. So these are the domains of the instrument. Medical variables were abstracted from medical records. Smoking status and history questions were developed using different guidelines and studies on smoking. Level of nicotine dependence was measured by Fagerstrom test for nicotine dependence scale. Self-efficacy was measured by a self-efficacy questionnaire, social support by social support inventory scale, and depression by the Center for Epidemiological Studies depression scale. There was single data entry. Logical and range checks were performed to assure accuracy of data. Analysis includes descriptive statistics and comparative analysis using t-test, chi-square, and Fisher's exact test, and simple and multiple logistic regressions were performed. Study was approved by IRB of American University of Armenia. So this is the flow chart of participants. North Marsh Medical Center provided 282 patients, list of patients. Out of them, 6 medical records were not found. 141 patients were excluded. 7 numbers were wrong and we couldn't contact them. 128 patients and relatives were contacted. Out of them, 3 were died, 8 were out of the country, 4 refused to participate in the study, and 10 were excluded because they identified themselves as non-smoker at the time of AMI. And we have completed 103 interviews. According to medical records, out of 214 AMI patients, about 59% were smokers at the time of AMI. And out of 182 males, mainly there are majority of AMI patients were males, and out of them 71% were smokers, and out of 32 females about only 10% were smokers. Mean age of the participants were 58, and all of them were males, and 54% of smoker patients quitted smoking, and 46% continued smoking. The main reasons for quitting smoking were health concern, advice received from the physicians, and family pressure. Main barriers for quitting were cravings for cigarettes, influence of other smokers, loss of weight to handle stress. And as recommended, the medical doctor should ask us and assess, advise, assist, and arrange follow-up for smoker patients. And we try to understand how it is done in the medical center. And 95% of medical records included smoking status of participants, but no information on smoked cigarettes and years of smoking were mainly missing from the records. Most of the participants 87% had received brief smoking cessation advice from the physician. 85% of all patients have tried to quit by using their willpower. Only one non-quitter patient used nicotine replacement therapy, nicotine patch, and many of them mentioned that they do not know any effective smoking cessation method, and no follow-up arrangement was performed. So this is the simple logistical regression analysis, and here I have included only those variables who were statistically significantly associated with dependent variable, and those variables are level of education, household monthly income, age of first cigarette, years of smoking, having smoker family member, number of quit attempts before AMI, other hospitalization after AMI due to heart disease, nicotine dependence score, and self-efficacy score. All these significant variables were checked for collinearity, and we found negative correlation between nicotine dependence score and self-efficacy. And two different models were developed. One which doesn't include dependence score. Here, as you can see, only self-efficacy sustained its significance, and which means that each unit increase in self-efficacy score increases quitting odds of quitting by 1.3 times. And the second model, which doesn't include self-efficacy, shows that only nicotine dependence score is associated with the smoking cessation. The other variables were not significant. So this is the first study on smoking cessation prevalence practices and factors. Our study limitations are, first of all, the fact that this is self-reported smoking status and no validation was done. Instrument was not validated in Armenian population. Retrospective data collection could lead to recall bias. Small sample size to explore associations with the other covariates, and the generalizability was limited because it is one-center study. Overall, the findings were consistent with the literature, and so to conclude, 59% of patients were smokers at the time of AMI. 46% of them continued smoking at 6 to 12 months after AMI. The recommended standard care for smoking cessation was not provided in the medical center. Patients relied only in their will for quitting and didn't receive professional assistance, and the level of nicotine dependence and self-efficacy